On behalf of Alliance Clinical Psychopharmacology Program, I would like to welcome you to the Ketamine in the treatment of mental health conditions, a primer. We're going to explore what experience and research show about the effects of ketamine when delivered within a therapeutic setting for individuals battling depression, suicidal ideation, and other mental health conditions. What does the data say about the use of psychotropic use of ketamine, and what's the way to achieve the best outcome with patients? We are going to learn the facts and fiction behind the power of ketamine in this fascinating webinar. We have Dr. Alex Papp, MD, ABPN, and Dr. Julie Myers, PsyD, MSCP. They work together in private outpatient setting at the Point Loma Clinic here in San Diego, and they teach courses in depression and PTSD in the Clinical Psychopharmacology Program here at Alliant. So I believe we're going to have Dr. Myers start the presentation. Dr. Papp will be taking over at some point. Dr. Myers, thank you for being here.
Well, thank you. So it's great to be doing this again. So there are some new data in here and a little more stumbling on our part trying to present that data. Some of the slides are fairly dense, particularly the talk by Dr. Papp. So we're pleased to be here. Dr. Papp is actually going to be starting off. I'm kind of just doing the intro thing, and he's going to be talking about more of the sort of deep science behind it, the chemistry of ketamine and the psychopharmacology, how it works and why it works, and how it really differs from some of the traditional antidepressants, and who is really, what are the indications for using ketamine with people. And then I'm going to take over in a more sort of the more practical side of what ketamine treatment looks like in the real world, and kind of remembering that, we have our own way of doing things. We're going to try to present how other people are doing it in a fair way, but we may have some slants and biases on this, but we'll attempt not to do so. And then, make sure we really present what are best practices in the industry and give you some case examples. So with that, I'm going to go ahead and turn it over to Dr. Papp, and we're kind of doing it the old-fashioned way. We just kind of move chairs in the same room. So here's Dr. Papp.
Good afternoon, everyone. Let's start quickly with the history of ketamine. Ketamine is the offspring of phencyclidine, which is PCP, which was developed in the 1950s for anesthesia in humans, but very quickly became clear that it has really bad side effects, including dissociation and causing psychosis, from which reason it was stopped being used in medicine. But of course, there was a reason why it became a drug in the streets that we still lived with. So that was in the 1950s. So by the 1960s, it was widely used in surgical settings, both for short anesthesia, for small procedures, and induction of full anesthesia. Then, of course, as we all know, ketamine also escaped medical practice, and by the 1980s became a popular rave and dance drug. Still to this day, I can't imagine how people can dance on ketamine, but clearly that's being done. Meanwhile, its medical use continued. There were a few studies, a few observations of people who received ketamine for anesthesia who reported their depression getting better. Eventually, somebody decided to make a very simple study, which was published in 2000 by a person named Berman. This was the outcome of the study. You can see that this is 72 hours. This is the treatment line. This is the placebo line. I'm not sure what scale this was, but this was the original depression number. And there was a very, very significant drop in depression numbers within 72 hours. This is not something that has ever been seen in psychiatry by any medication. It was so unusual that it took at least 5 years for the next study to be conducted. But after that, eventually, slowly, it became more and more widespread in academic institutions, dripped out into private practice. And by 2020, there were already 500 known ketamine clinics in the US, and by now there's over several thousand. So let's see what ketamine actually is. A ketamine is a molecule which comes in two forms, the left form and the right form. These are called racemic mixtures. And you can imagine very much like your hands. So your hands are actually racemic mixtures of the thing called hen. One side is called S-ketamine, which is the left side, the other side called R-ketamine, which is the right side. The different versions, different mirror images are called the enantiomers. This is a mirror symmetry That is observable in many medication. In fact, most of medications that you take comes in a racemic mixture, but many times it doesn't matter which side is active because they're both equally active. There's one medication that most of you have heard about where the racemic differences are significant, and that is in with respect to Celexa, which is citalopram, and Lexapro, which is escitalopram. So let's see how it actually occurs in real life. So there's S-ketamine and there's R-ketamine, like as I said. The S version of ketamine seems to have a higher affinity for the NMDA receptor than the R, which means that it activates it more readily than the R. On the other hand, the R version seems to have a longer lasting antidepressant effect in animal studies. Because of this known effect, the higher affinity, the drug company that first decided to market ketamine, decided to go with the S-ketamine. It turns out that maybe R-ketamine would be better long-term or more effective, even though you need a little bit more per patient to achieve the effect. R-ketamine is currently under development as an antidepressant. And S-ketamine, as we know, has been approved for several years as in a form of nasal spray called Spravato. The ketamine infusions, injections, and many of the other formulations used in medical settings are all using the original racemic ketamine. As I was told by an attendee of a conference about ketamine in Oxford, this person was from Brazil, and he said that to his knowledge, Brazil is the only country in the world where actually S-ketamine is the only ketamine available in terms of pharmacological use. Let's see what happens with ketamine in the body. Ketamine is metabolized like every medication or most medications is metabolized by the enzymes in the liver, the CYP enzymes. The two major enzymes that metabolize ketamine are the 384 and the 2B6. The first step is metabolized by 384, and the other steps are metabolized by the 2B6, and there are other side branches that are metabolized by other enzymes, but these are the most important ones. So the first breakdown product is called norketamine. From that, we get hydroxynorketamine, which is an interesting product on its own and usually just simply referred to as H and K, from which we get dehydroxynorketamine, etc. So you can see that ketamine goes through a lot of steps, which results in it breaking down. Now, the interesting thing is that most of the breakdown products are themselves psychoactive. The total action of ketamine eventually comes from the combined effect of the original ketamine and all these metabolites, both the S and the R form. This is called an entourage effect. You can see entourage effect in medications like agents like, for instance, St. John's wort. It contains dozens of different kind of pharmacologically active chemicals. The combined effect is called an entourage effect. Cannabis contains lots of different chemicals, and the total effect is an entourage effect, which also means that because of all these known variations in terms of enzyme activities in people, some people have more of this in their system circulating. So it is hard to say what exactly is the total full effect of the entourage, depending on the situation. You can see what happens if you give ketamine intravenously. So this is a slide that describes the effect of the blood levels of ketamine and two of the byproducts, norketamine and hydroxynorketamine. The gray column is the time during which ketamine is administered intravenously, is usually 40 minutes. You can see that ketamine goes into a system that continues to go up, but then it begins to turn downwards because the metabolism begins to start. You see that metabolic products are increasing, and very quickly they take over most of the effect of ketamine, and ketamine itself is declining very rapidly. So first norketamine and eventually hydroxynorketamine are increasing, and they take over the effect of the parent compound ketamine. Like I said, it occurs both for the R and the S versions equally. Now, what happens if you give ketamine orally? When you give ketamine orally, most of the medication is metabolized by the liver before it reaches the bloodstream that eventually circulates it to the brain. So most of the ketamine, and this one is a different study, and they did not show hydroxynorketamine. So this would be the norketamine the concentration of noradrenaline increases, and the ketamine itself barely budges because most of it gets metabolized by the liver before it reaches the general circulation. Hydroxynorketamine would be something like this, going out like this and then goes this way. Another thing that I would like you to look at is the length difference. So this is 3 hours. So this is 5 hours, 300 minutes. It is represented by this red line. It is the same length here. It is 5 hours here. So you can see that with IV administration, within 5 hours, most of the effect is completely gone. In oral administration, at 5 hours, you're just having the peak effect of noradrenaline, and then you start having the peak effect of the hydroxynorketamine. So you can see there's a huge difference between administering ketamine IV, and IM is fairly similar to this, versus any other administration that does not bypass the liver. So when you say, I got ketamine intravenously, or I got ketamine sublingually, you got a really very, very different treatment. Let's see what happens as ketamine as it affects the brain. We're going to look at the cellular effects of ketamine, and we're going to look at the macrocellular effects of ketamine later. This is up here just to give you an idea of the complexity of the process. This is not something I'm going to talk about in any detail, except the fact that the main effect of ketamine that we're looking for is an increased glutamate effect in the prefrontal cortex and some other structures, including the hippocampus. This is the main thing that we're trying to achieve, both with ketamine and antidepressants in general. And then it has other effects that eventually feedbacks into the antidepressant effect that we're trying to achieve. So with ketamine, all kinds of things happen. Then glutamate activity increases in this particular brain structure and a few others, which then result in an antidepressant effect. Things to understand is ketamine increases glutamate activity in prefrontal cortex. The key effect of ketamine is an NMDA receptor blocking effect. The NMDA receptor is a glutamate receptor. So how come you're blocking a glutamate receptor and you're increasing a glutamatergic activity in the brain? Well, it is the result of the inhibition of inhibition. So let's see what that means. Here's a little graph. It's a very schematic graph of a part of the brain that it would be in prefrontal cortex. So there are so-called NMDA neurons that give a certain baseline activity to GABA neurons. And most of you know that GABA activity is inhibitory. So if there are NMDA neurons that are activated by glutamate, there's a normal course of action. That's going to activate, to some degree, the GABA neuron. But it's an inhibitory neuron. So what happens if an inhibitory neuron is working? It is going to inhibit something. So the downstream effect of glutamate on the NMDA receptors is through increased inhibitory effect because of GABA neuron activity. Now, what happens if you block? And so the other side of this graph is when ketamine blocks the effect of glutamate, then this neuron is not giving as much excitation to the GABA neuron in this system. The GABA neuron, as an inhibitory neuron, becomes less inhibitory, which means that there's going to be a disinhibition. There's a reduction of inhibition in the downstream processes. And that's how blocking the glutamatergic activity on this neuron overall increasing the glutamatergic activity in another part. Now, studies show that when you block the NMDA receptor, it removes the excitation on the inhibitory neurons. And here, the general glutamatergic neurotransmitter activity, the AMPA activity, is going to increase. NMDA neurons are very specific. They occur in very specific part of the brain. AMPA receptors are widespread, the general baseline garden variety glutamate receptors in the brain. So it is not going to be increased everywhere in the brain, this activity, except in the parts of the brain where there is NMDA neuron. The overall effect, as we're going to see on the next few slides, is an increase in synaptic growth, which can be shown in studies to be correlated with reduction in depression. So when this happens, the activity of prefrontal cortex increases as a result of glutamate or ketamine, then there is an increased production of these neuroplasticity factors, the BDNF, mTORC1. BDNF is brain-derived neurotrophic factors, and mTORC1, if you want to know, it's mechanistic target of rapamycin complex 1. These are very important large molecules. If their activity and number increases in crucial areas of the brain, it results in synaptic growth, even in growth of creation of new nerve cells sometimes. and that is correlated with the antidepressant effect. So this is the chief cellular effect of ketamine. There's another effect is the opiate receptor blocking effect is a secondary effect. It can be shown that if you block opiate receptor, then the effect of ketamine is dampened, but this is not eliminated. And obviously opiate receptor blocking is not enough, it's not sufficient. So it's neither sufficient nor it's neither necessary nor sufficient, but it is an added effect that contributes to the effect of ketamine. There are many other effects. There's some effect on reuptake molecules and some serotonin receptors, but they don't seem to be clinically significant. So let's see these cellular effects of ketamine in vivo. There are some really fascinating studies that can be done nowadays on live animals. This is a live animal, a mouse, I think. It is the visualization of a single dendrite. And the advantage of this technique is that you can repeatedly visualize the very same dendrite. So this is really a fascinating thing to me. So this is an animal that is normal, free moving before depression. Then you can model depression in animals in different ways. I put them in water and see when they stop swimming. But there's one way of doing it, and this is how they did it. They gave the animal a steroid. The steroid leads to a depression-like state in the animal, so now it's considered to be an animal model of depression. So when you visualize the very same dendrite, you can see a few things. That some of these dendritic spines completely disappear. You can see that the width of the dendrite is shrunken, and you can even see that the other synaptic dendritic spines look shriveled up and degenerated. The dendritic spines are the points where the synapses occur. So every dendritic spine is a synapse to another cell, another dendrite, or maybe another axon. But this is a single one that's visualized. When you give ketamine, you can see both that the width of the dendrite is recovering, and you will see that some of the synaptic dendritic spines that disappeared are reappearing. And in the studies that they see that the animal which acts depressed in this state no longer acts depressed after ketamine was given. So this is a very poignant representation of the cellular effect of ketamine, which is actually correlated with the antidepressant effect. So basically what ketamine does, ketamine restores normal physiological functioning. Okay, so let's look at the effect of ketamine on brain structures. We'll look at cortical structures, which is the prefrontal cortex, hippocampus, and we are going to look at subcortical structures, the amygdala, and the lateral habenula, which is an interesting little structure that recently became the focus of attention in ketamine studies and also depression studies in general. And then we can look at large-scale networks as well and see how ketamine affects them. So let's see what ketamine does on cortical structures. In the prefrontal cortex, which is the seat of executive function, and it is part of the central executive network, and we're going to talk about these networks a little bit later. It leads to glutamate release, this particular mechanism that I described here. It leads to synaptic potentiation, which counteracts the synaptic atrophy seen in depression, promotes the growth of dendritic spines, which enhances the synaptic strength, and like I said, it correlates with the resolution of depression. Now, in the hippocampus, which is critical for memory formation and also spatial navigation, which is part of the default mode network. It promotes a very similar process called a long-term potentiation. It's a process strengthens connection between neurons, and it is the basis of learning and memory. During the ketamine effect, this is what is interesting here, glutamatergic transmission is temporarily disrupted. And that's when people are tripping and seeing all kinds of things and imagining things, and the world looks different, and they are in a total different realm. And then it reconstitutes itself, they come back to reality. And sometimes it is described metaphorically as if, let's say you have a jar with a whole bunch of marbles, like compacted together, years of, just pressure and lack of activity. And then you shake it really vigorously and you allow the marbles to settle into a different pattern. That's sort of the metaphor that you can use to conceptualize what happens in the brain, especially in the hippocampus, when new learning can occur. And that is the state of mind when the settling occurs. And of course, the settling occurs not in a few seconds, but settling occurs in the course of hours and a couple of days, when people are more, and I think Dr. Myers mentions that people are more apt to learning from psychotherapy. That's when psychotherapy can be more effective. Right after and the shaking of the marbles of your brain occurred. And that's subsumed under the concept of neuroplasticity. Now let's look at subcortical structures. The amygdala is a very, very important part of the brain. Now it is central to emotional processing and of the fear response. It is overly active in PTSD, for instance. It shows really significant sexual dimorphism. It is smaller in women than in men. And it probably has a lot to do with, for instance, women's higher sensitivity to developing PTSD. And it's part of the salience network. Again, I'm going to talk the salience network in a few slides down. In PTSD, this is where it's most relevant. There's an hyperactivity of the amygdala, which leads to behaviors like increased startle response and hypervigilance. Ketamine reduces the hyperactivity that is seen in PTSD, and that leads to the improvement in hypervigilance and startle response. Sometimes we see it in really dramatic terms. Yeah, not directly on the amygdala, but it has effect on the amygdala from the prefrontal cortex, which is supposed to keep the amygdala under control via a inhibitory effect. PTSD, because it increases the activity, restores the activity of the prefrontal cortex, restores the control, the ability of the prefrontal cortex to control the amygdala, which another way it reduces or improves the effect of PTSD. So it's both directly reduces the activity and also increases the inhibitory control by the prefrontal cortex over the amygdala because of improved activity or performance by the prefrontal cortex. Now let's look at the other subcortical structure, which is called the lateral habenula. It is a tiny, tiny, tiny little sliver on the two sides of the brain. You can imagine it as like two shells, very small, 2 millimeter wide, and 3-4 millimeter long thing that I think it surrounds one of the channels in the brain. It's not part of these major networks. It is part of the limbic system, and it is considered to be part of the reward and aversion network. It is part of the brain that is activated by failure or punishment, and it's also activated by pain and stress, sometimes called the anti-reward center. Recently, in the past 5-6 years, it was shown that the activity of the habenula increases in chronic depression. So it is active as if the person were under punishment when it is not, when he or she is not. So it's a chronically activated part of the brain that makes the person act as if there were pain and stress and failure and punishment, which is probably one of the reasons why these are cardinal symptoms of depression per se. Now, the activity of this chronically overactivated lateral habenula is called the burst firing. In electrical recordings, it looks like this. What ketamine does is simply eliminates the burst firing. The clinical response occurs immediately within a few milliseconds. It just stops happening. Obviously, the antidepressant response, it doesn't occur within a few milliseconds. It takes good minimum a few hours and up to 24, 48 hours. But seems to be that something that's the very, very first step that eventually leads to all the other steps, the NMD receptor blockage and the inhibition, non-inhibition, etc. So very interesting stuff. I think we're going to hear more about that. Actually, we were last time at ketamine conference, and somebody came up with an idea to somehow try to get ketamine just to the lateral habenula, nowhere else, and see you can reduce the overall ketamine effect on the body, just deliver ketamine to the lateral habenula with different kind of interesting means. So people try to do something else. Really cool stuff with this. So let's look at the network theory of depression. So let's look at the network. The networks, as we understand them in the past 15, 20 years, are not the original networks which were anatomically based. You saw a center here, and then fibers were going this way and fibers going that way, and then became like a network. These are parts of the brain that tend to activate together, and they are not necessarily like macroscopically, anatomically easily seen to be connected, but you can see them being connected on functional studies like functional MRI, PET scan studies, tensor imaging studies, etc. Now, 4 or 5, or maybe now 6 or 7 of these networks have identified the 3 major ones that are relevant to depression in psychiatry in general: the central executive network, the salience network, and the default mode network. The central executive network is easy. Basically, it's the network that is involved in sustained attention, complex problem solving, working memory. The salience network is part of the brain that is involved in detecting and filtering stimuli that only the salient stimuli reach the brain. So, cat meowing is not going to be noticed by, but the car, going towards you and speeding up, that's going to be noticed by. It also is going to recruit the relevant functional networks. Car speeds behind you towards you, then the salience network is going to make the part of the brain active that's going to make you jump away. Throughout the interconnectedness, the salience network contributes to a variety of functions like communication, social behavior, and self-awareness through the integration of sensory and motor and cognitive activities. The default mode network is an interesting part of the brain, which is active when you are not active. When you as a person are not really active, you're not looking, you're not scanning, you're not thinking, you're not trying to solve a complex mathematical equation. It is active when you are at wakeful rest. It occurs when you're doing daydreaming, wondering, but also when you're thinking about others, thinking about yourself, you're recalling the past, planning for a future. So these are very focused, self-absorbed activities. The more active the default mode network, the less active the other networks are, and vice versa. In depression, there's an intrinsic hyperconnectivity in the network itself. There's an increased strength of connection between the parts of the default mode network, which you can see that there's a lot of different important structures: the cingulate cortex, the medial prefrontal cortex, angular gyrus, hippocampus, etc. So the activity of the default mode network is intrinsically, chronically increased. That also translates into an increased activity, increased strength of connection between the default mode network and the salience network, which means that, as I said, the more active this network is, the less active these networks are. So there's a decreased activity in the salience network, also a decreased activity in the central executive network in depression. The result of these decreased functions is that there's going to be poor working memory. There's going to be poor, for instance, as I said before, there's poor inhibition of the amygdala, for instance, because the central executive, the frontal cortex is not active enough. There's going to be poor motivation. These are all symptoms of depression. And due to the increased strength of this connection here, there's going to be increasing rumination because the person is going to be repeatedly inward focused, even if that would be more advantageous to focus on something in the outside world. Poor autobiographical memory, which would represent itself in difficulty recalling positive events from the past, basically like in the past it used to be called state-dependent learning. So this is the state of the networks in depression. There's frontal hyperactivation, there's weak salience detection, and there is a default mode network hyperconnectivity within the network itself. What ketamine does, it normalizes the hyperconnectivity within the default mode network in depressed patients. So it reduces the strength of connectivity. This will not be seen in healthy individuals. Healthy individuals whose connectivity is what it's supposed to be is not going to be decreased by ketamine. I mean, long term, when you're tripping, everything is different. But it is going to normalize, after repeated ketamine treatment, this hyperconnectivity within the default mode network. With that occurring, there's going to be less strength of connection with this to the salience network, which is going to recover from the oppression exerted by the default mode network. So the balance between introspective and externally focused activities are going to be restored. It increases the activity of the central executive network, which of course is going to be the factor that's going to lead to the improvement in the activities of daily living, working memory, concentration, etc. Now, these effects can be noticeable after a single treatment. A single treatment has a very limited effect. When you give a single treatment, you can see that there's a very quick improvement. This is the MADRS score. This is one of the depression rating scales that's used mostly in research. So there's a quick reduction in MADRS scores. Again, you would never, ever see anything like this with a traditional antidepressant. And then by day 7, it shows a clear going back to the depressive baseline. This is the study from 2000, the Berman study. I just repeated it here to see that this is very similar to that study. You can recreate this study over and over again. But if you give repeated infusions or injections, any kind of treatment, then this recovery of depression, going back to depression, does not happen. So just continued improvement of depression scores is going to be seen. It is not a evidence-based piece of data that you have to give 6 initial treatments. That's just how it developed in clinical practice. But within 6 clinical treatments, you get a long enough, enduring enough reduction in depression scores. Now that takes us to the comparison of traditional antidepressants versus the new antidepressants. When you give traditional antidepressants, the SSRIs, tricyclics, etc., the main effect of these medications is to give a kick to the serotonin, norepinephrine, and dopamine system. That the kick occurs, whether it's reuptake inhibition or something else, it can be seen within hours. Studies show that the receptor is active within a few minutes, and then the downstream activity begins to occur within a few hours. The second, third messenger systems. But it's clear that antidepressant effect does not occur in a couple of hours. It takes 3 to 8 weeks for the next stage to sort of churn through the brain. And these are the steps that lead to BDNF and mTORC gene expression. And this has to do with things that occur in the nucleus and DNA and messenger RNA and other kind of things. And those have to be transported down in the dendrites at the end of the axon, etc. So it's a very, very long process. A lot of things can go wrong. But eventually, the exact same thing happens with the traditional antidepressants, your Prozacs and Lexapros. Eventually, you get an increase in BDNF levels. You see an increase in synaptic proteins. You get an increase in number of neurons and dendritic sprouts. But again, the advantage of ketamine, and again, I just put this little graph here to remind you this is where it happens. It occurs at this point of the process, so it bypasses all those long and complicated processes that lead to this point that are the features of oral antidepressants. So a lot of advantages besides the speed, also the fact that there's no constant side effects, the weight gain, sexual side effects, there's no daily medication taken, there's no daily medication side effects. Okay, so let's leave the science behind and let's look at just the psychiatric science, so to say, from basic science to medical psychiatric science. What are the indications of ketamine treatment that are primary and secondary? The primary is definitely depression, non-psychotic depression. We frown upon giving it psychotic depression, but it's mostly theoretical, but probably, again, there's no studies showing it in any effect there's no data in psychotic depression, so we're just not doing it. But depression, any form of depression, including what used to be called treatment-resistant depression, bipolar depression, even dysthymic depression, or any kind of depression, ketamine is going to be effective. The next very important indication is suicidal ideation. With depression, without depression, with a psychiatric indication, disease present, or without, suicidal ideation is one of the most dramatic improvements that you can achieve when you give ketamine to patients. In fact, there are many patients whose depression improved spectacularly, but the suicidal ideation was completely gone, and that's the main reason why they continue to get the ketamine treatment. And then we have PTSD, which is the third major indication. You can have anxiety disorders, OCD, eating disorders, and substance abuse disorders, with the caveat that ketamine itself is an abusable substance, so you have to be careful how to administer it to patients. Alcohol use disorder seems to be responding well to ketamine treatment. These are the side effects. Can have elevated blood pressure and heart rate. These are almost never serious. Some patients may require antihypertension pre-medication, nausea, and/or vertigo. That occurs a little bit less frequently, but may require anti-nausea medications. Vomiting is very rare, mostly when people come in with full stomach, which they should never do. Anxiety can occur during the trip because of the subjective experience. I used to give patients benzos, but now I just talk them down. And officially, the psychedelic effect is considered to be a side effect most patients actually like. In the afternoon, evening, the ketamine wears off. You can have nausea appearing then. You can have lightheadedness, some headaches. And for the next few days, some patients report some difficulty falling asleep, but then it goes away. There is something called an emergence reaction that occurs in anesthesia setting when patients are getting much higher dosages of ketamine. As they're coming out of anesthesia, it's confusion, agitation. With imagery, in psychiatry, we don't give high enough dosages that it should be a problem. Long-term side effects, we just don't know, unfortunately, because there's no long-term studies. Long-term studies are done with drug companies, and there are no drug companies that would do long-term studies with IV ketamine, because there's frankly no money in it for them. So we just don't know. There's an unknown potential of triggering addiction, likely very low, but you have to be aware of the possibility. There's some concerns about liver function, and there is some concern about urinary cystitis among heavy ketamine users, I think it's called destructive cystitis or something really horrible that destroys the bladder of these patients completely. It never happens in the clinical settings because we just don't give enough and frequently enough. Basically, these patients have ketamine in the system 24/7. Well, we do, so you order liver function tests and urine analysis a few times a year just to make sure that we're not missing something. There are some medications that interact with ketamine, and these are the medications that block the two enzymes, the 3A4 and the 2B6, and same with the enzymes that might induce those medications. So you try to avoid them. And there's pharmacodynamic interactions, which means that they just interact with the effect of ketamine in the brain. Benzos and opiates can extend the sedative effect, and they can also reduce the antidepressant of ketamine. Other NMDA receptors, especially lamotrigine, compete for the receptors, and that's how they interfere with the effect. People on lamotrigine, which occurs quite frequently with depression, need to skip to lamotrigine on a day of ketamine administration. For the contraindications, very few: stable heart disease, unstable epilepsy, psychosis, glaucoma, severe liver disease, substance abuse, pregnancy, because animal studies show that NMDA receptor development is affected. Children, we just don't have data, and therefore we're not recommending. So, summary: the benefits are observed within hours, can be extended if repeated administration. The adverse effects are very mild. Much is known about biological effects, as I described, but we don't really know how it affects, how it transforms into the antidepressant effect. And the main reason why doing it is depression, suicidal ideation, and PTSD. And with that, I will hand it over to Dr. Myers.
Okay, so a lot of information, and we're going to be using some of that information to understand the more practical effects. So it's not necessarily what you think. So people have all sorts of ideas about it. It's done differently by different people. People experience it differently. So let's see what some of the real facts are. Again, we have our own biases about how we do it, but let's see what other things are important. One thing to think about is the route of administration. So they're basically for the IV, the IM, the intranasal, and the oral. And part of the reason one of these is chosen is first with the clinician, what the clinician feels comfortable with, but also what the patient chooses. So it sort of started with the IV use of ketamine. And that's basically because it was started by anesthesiologists in academic centers and hospitals. And so there's quite a bit of data on it. And that uses the racemic mix, both the right and the left hand side. And then the IM is also using the racemic mix. And it has a similar efficacy to the IV. Along came the intranasal Spravato. It's only the S-ketamine that is used. It's FDA approved. It's generally considered to be less efficacious than IV. And there's also a compounded racemic mix that, again, is used off-label. It's not FDA approved. And finally, the sublingual oral is the racemic mix. And you might have heard these troches. One of the issues with the oral is that it's generally unregulated, sort of Wild West out there, very low concentrations in the oral mix and limited data, and it's often questionably legal. So there was one physician, for example, who got himself licensed in all 50 states and was just sending it out and making a lot of money. And there's also this extended release formulation in phase 2 clinical trials. The provider is going to decide what they're comfortable with, but there may be some good arguments for use of any one. For example, S-ketamine, even though it may be considered to be less efficacious, and it's a little messier, tends to just sort of drip out their nose and things like that. But it's covered by insurance. So for some people, this is a necessary thing to have the insurance covered. It has some standardized protocols that go along with it, more legal protection, really, because it's FDA approved. And there's some evidence that it's a little bit better for the maintenance phase of ketamine. And then the ketamine itself has basically more rapid, robust response and offers more flexible dosing. So the IV or the intramuscular. And there's a lot more clinical experience with it. We do not recommend in our practice, the oral ketamine, simply because of this sort of unregulated market that happens with it, and plus more likely to be abused. We heard of one patient who's like, it was just being delivered on his doorstep. And so again, the potential for abuse is a little bit higher. So in choosing what route of administration you're going to use, you also want to think about the bioavailability of the drug. And Dr. Papp sort of presented the different metabolites that happen with the oral ketamine, for example, esketamine. There are going to be more metabolites that are having more effect because the ketamine is subject to first pass metabolism by the liver, and so not as much gets to the brain. So this lower bioavailability of the oral medication means that the metabolites are going to take a stronger role in the effect. The IV and IM reaches the brain without encountering this first pass, the metabolism by the liver. Oral viability is only about 20 to 30%. And even though you saw in the diagram that the effect of the oral ketamine with the metabolites lasted longer than the 5 hours that is for the IV ketamine, does not mean necessarily that it is having better effect or more effect just because it's lasting longer, because we're really talking about the downstream effects of the ketamine, which is the most important part of it. So that patient is actually experiencing the more psychoactive parts of the oral ketamine for much longer, which makes it a little more, I would say, dangerous in that they are affected by this psychoactively rather than it doing exactly what you want it to. So just because it's longer doesn't necessarily mean that it's better in that sense. And then the other thing thinking about the choice would be the strength of the peak effect. So the IM has a stronger peak effect to it than the IV, which is stronger than the intranasal and stronger to the oral. And this sort of the stronger peak effect means that there's going to be less engagement with the outside world. So, for example, if ketamine-assisted therapy is important in the process, there's going to be less ability to communicate with the IM. So, what's the right way to give ketamine when you're adding psychotherapy to it? There is no one way that it works. They all basically are taking advantage of the ability of the brain to rewire things, to create more neuronal connections. So you can do it with psychotherapy, no psychotherapy, after, before. We're going to look at each one. In our practice, we have done all of these, and we've sort of honed it down to the way it seems to work best. That for both us in the practice and for the patients that we treat. And I would say if there's no therapy at all, we want to really think about having support for the patient in some other way. So you can just give the ketamine and the drug is still going to work. There are ketamine clinics that treat many people all at the same time without any support at all. We don't do that way. Even if there isn't therapy going along at the time of administration, Dr. Papp is always with the patient the full first time, and then only is with that patient during the rest of the treatment. He doesn't have multiple people at the same time, but some people do in ketamine clinics. We don't have a ketamine clinic. We have full psychiatric and psychological services, and so along with that it's just part of our practice, the ketamine. So you can also have therapy timed to the ketamine administration. Especially within the first 24 hours. So because the brain is most neuroplastic at that time, 24 to 48 hours seem to be the time where it sort of wears off a little bit. There's evidence for timing CBT or other types of therapy to integrate the material for the patient within that 24 to 48 hours is very helpful. Really fascinating study coming out with exposure therapy. We heard at the last ketamine conference in London about doing written exposure therapy with it as successful. So we're kind of waiting on that paper to be published. You can also have therapy at the time of the ketamine administration. Again, that's called ketamine-assisted therapy, or it's got some other names to it, but there are many, many approaches to this. And again, less viable with something like IM, just because the peak effect, people are really just sort of out of it too much for the whole part of it, but you can still do the ketamine-assisted therapy with the IM. There are all sorts of training groups that charge a lot of money to learn ketamine-assisted therapy. Really, the truth is there is no one right way to do it. Psychodynamic, internal family systems, inner-directed, supportive therapy, they're all basically doing the primary thing, and the primary thing is to make the patient feel comfortable and safe in the session. So these faster routes of administration could be too much for a lot of interaction. But the higher dose, the more psychedelic experience. So finding that right sort of dose for the patient. Some people hate the psychedelic experience. Some people want the psychedelic experience is going to be important. If they really are scared to death of the psychedelic experience, you take it very slowly in terms of the approach of that. So again, many ways to structure the ketamine process. Some are good, some are not so good. Just mailing out ketamine to people in the mail is not particularly a good practice, looking at sort of the different phases of the good practice. So in general, these 4 phases are intake, then before each ketamine administration, their experience itself, and then the integration of the material. And I'm later going to be presenting sort of what we do in our practice for that to maintain the good practice part of things. So the first phase is really the intake with providers. And, you don't want to really bring people into your practice for ketamine if they're not appropriate. So Dr. Papp always starts with a full psychiatric interview, which is a couple hours. If the main goal is to have ketamine, then you need to screen before they even get in. A form is sent out to the patient so they can determine if they're really appropriate for ketamine or not. And Dr. Papp discusses it with them, or I discuss with them. So we want to have the sort of in the intake with the provider. If they are doing ketamine-assisted therapy, or I'm going to be part of it, then do you have an intake with both of us? Some patients choose to have me involved. Some people do not have me involved. Some people have their own therapist involved. There's a wide variety of ways to do this. The first session is really going to be, is the patient appropriate for ketamine? Are there any contraindications? And you want to get baseline assessments. You want to use a PHQ-9 or the Beck. And you'd be surprised how few providers actually do any measurement. I mean, does this patient really have depression, for example? And is the treatment working? They're not taking any sort of measures on that. And then you want to kind of give them an idea what the ketamine process is going to be like. So in general, the minimum 6 sessions scheduled in 3 weeks. So if they've got a really busy work week for 3 weeks, that's not the time to do it. You want to find a time that they can really devote themselves to the treatment, and you give them sort of cautions about their medications and things like that at the initial session. Many providers say you have to pay for the 6 sessions up front, all in one package. We do not do that. It's just you bring them into the practice. Are they appropriate for ketamine? And if they do a ketamine session and they hate it, why would you make them come back or lose the money? The data says that these 6 sessions is really where you start to see it. So you try to encourage them to keep with the 6 sessions and plan for it up front. So that phase 1, where we do this guidelines and planning, and I'll show you the documents that we use for that, so they can get a really better idea about how they can make the most of the ketamine experience, because there are things that are helpful and things that are not so helpful. Again, with providers, we generally, encourage look at the patient rather than just the narrow depression piece of it or the PTSD part of it. What is the whole psychiatric look of the patient? Phase 2 is before each ketamine administration, the patient comes in. If you're doing an IV or an IM, you need to know the weight of the patient. Of course, if it's just within the 6 weeks, there's not going to be a great variety of weight, but if they're coming in more irregularly, you would want to weigh them each time because dose is weight dependent. And then you want to get their blood pressure, heart rate, temperature, and other medical cautions. Did they drink a lot last night? Did they forget and they took their medications? And then sometimes we've had to send people home because their blood pressure is just too high. So they need to get it down before they can come in. And clearly, if they're ill, you don't want to put them through this process. And then there's certain medications that are given to pre-medicate. For example, propranolol, if there's a fast heart rate, and some other things, ones to sort of deal with the nausea that the patient may have. So some of those might be given prescription before the patient comes in. Sometimes they're given in the office. And then make sure that they've skipped things that they should not be taking but when they're having the ketamine. And then each session, we do at least the PALMS, profile a mood state, or you can use any other measure. Again, most clinicians do not do that, but it's to see like, well, what's the patient coming in with, and then what is it after the session. Some people like to have an intent or goal of the session, but not everybody does. It's not important. It's more just having a open sort of approach to the ketamine is generally what we advise. And then they're going to review, of course, the transportation and plan after session because they cannot drive home. We know a patient who actually just was still in sort of a dream state, was just let out the front door and wandering the streets and got lost. So we want to know what the plan is for them afterwards. So there's a 2-hour block set aside for each patient. The first 15, 25 minutes is going to be prep, and then about 40, 70 minutes of tripping, and then 15 to 25 minutes debriefing. This is just sort of a general length of time that happens. So that's the first 2 phases. Part of the whole picture is going to be the set and the setting, words that you may hear quite often. So the set is basically the mindset of the patient. What are they coming in? What's their state of mind, their mood, attitudes, and concerns, things like that. Are they in a sort of an agitated state when they come in? And then the setting is the physical environment. So ketamine was originally given in more this sort of surgical-like setting, but these have evolved. You just wanted to have comfortable, inviting, and safe, warm for the patient. You know, what they like, what will make them feel comfortable. And it's also making the patient feel comfortable and safe and calm is actually very, when you consider what happens with the lateral habenula and the fact that we know that stress, it's actually stress that dislodges the ketamine from the lateral habenula. It's really vitally important to have the patient be calm during the session so that it doesn't dislodge from the lateral habenula. And the third phase is the trip. So first onset is some altered perception. So this is with the IM. I can speak to. I have not worked with the IV, but the onset of the altered perception is about 2 to 4 minutes after the injection, and then this peak effect is going to be about 10 to 25 minutes, and they are just sort of out of it for that time. You want to monitor the blood pressure, heart rate, OT saturation, just their general state. So we have pretty sophisticated monitors where, and we're watching them all the time while the patient, Dr. Papp, is monitoring all the vital signs and has a camera on the patient if nobody's in there with them to make sure there's not an agitated state that happens. So you got it all sort of set up for the monitoring, and then you administer the ketamine. And really the role of the provider, again, no matter what your theoretical orientation would be, to let the patient control the level of intervention they want. Some people want to talk, some people don't want to talk. Empathetic listening is really what we all do as therapists anyway. So, if you're a therapist of any kind, you all know how to do that and make them feel safe and contained and encourage curiosity and a sense of awe. So it doesn't have to have some big intent like I'm going to go resolve my conflict with my mother. Just, what happens? Just be there and experience what's happening. And then when I'm in with the patient, if I'm doing ketamine-assisted therapy, I record the dialogue and the behavior so that I can then discuss that with the patient later. And then the fourth phase is this integration of the material. So the first integration is right after the experiential phase. And so they're going to encourage them to connect with the material, about what they experience. How are they feeling about it? There's actually then measures that are taken again. So the PALMS is filled out again, at least in our office. They often record about what their experience was like. And you want to make sure that they're medically sound before they leave the office. So the medically sound is going to be, they have to be oriented. They can't be sent out when they're still in a state of disorientation, and make sure they have a safe ride home, and remind them no driving for 6 hours or heavy machinery, any of that sort of thing. They leave the office, encourage them to recreate the experience. Go home, sit in an easy chair, play the same sort of music that you listen to in session, and hopefully have some follow-up therapy within the first 20 to 48 hours. But the primary thing, and I put it there, is that avoid stress. So the idea that the ketamine is basically blocking that anti-reward center in the lateral habenula is super important. If you go get in the car, someone's driving home and you're getting in your car with your spouse and you start arguing, you've already started the process of dislodging the ketamine from the lateral habenula. So it's amazing. People just do the ketamine session, then they go right back into their same pattern of arguments or stress. So that's something that we have really stressed in the last couple of years because of the new information that came out about it. What are the other elements of good practice, right? So, I mean, anytime you give any sort of medication or any kind of therapy, you want to follow good practice because, you get better results from it. So people do it differently. Again, some people don't do it at all or do bad practice. But what we have developed over the course of seven years, this has been going on. It's just kind of like honed how we do it. What we've added in the last couple of years was this planning session that we do with patients. Not everybody is willing to do it. You tell the patient you're going to have better outcome if you do this sort of thing. But in general, most patients will do it. I go over really what the ketamine treatment is going to look like, at least how we do it. What do we know about ketamine treatment? Are you going to get the most out of it? Sort of explaining some of the terms of it. And then going over them again about the sort of timing of the ketamine treatment that, they really didn't tell the truth that they don't have stressors coming up and they're remodeling their kitchen. They're going to be under severe stress during this. Well, maybe you want to rebook your sessions for a better time. And then the other part, go in great detail with them that the days before the ketamine treatment, what are they going to do? So they got to minimize their drugs and alcohol. If they're using alcohol, we have to figure out a plan how they can reduce for those days, because you're not going to tell somebody who is drinking suddenly to stop, because that can be life-threatening in itself, but make sure that they're not drinking before the session, arranging for in bold, conflict-free ride, and arranging for their psychotherapy with either somebody outside of our practice that's going to help coordinate it with them or with me. What are they going to do the day of treatment in terms of reducing the stress that they have during that day? And we talk about what are the things that they're going to bring to treatment. Some people like bringing their own stuff, right? In the first session, maybe not, but after that, do they like to have a playlist, which we encourage is something that they can listen to before the session, they can listen during the session, they can listen to it afterwards, and it helps sort of recreate the experience. And then they can bring other things with them to session, like a blanket or pillow, things like that. We always provide them, but some people like to bring their own. And then again, if they want to set an intent, you try to make it more general, a sense of awe and peace and things like that. And then the next part is, before your appointment, what are the guidelines about what are you going to do before? You're not going to have a big breakfast if you're walking to the clinic, because you're not going to keep that in your stomach, right? Wearing comfortable clothes and reducing stressors. But the data shows that the period before the appointment with stress isn't nearly as important as what the stress afterwards in terms of the ketamine effect. Although we've had many patients report that when they come in a really foul mood, it really affects how they're experiencing the ketamine. And so they don't want to come in if they've been disturbed. They're not able to let it go as much. There's some people that are actually using oxytocin in their practice to sort of make the feeling within the appointment itself less scary for the patient or nicer. The data doesn't say it has a lot of effect on the efficacy of the ketamine, but it does make the experience for some people better. Some people makes it worse. So it's something that can be done. So during this appointment, the setting is emphasized. And then what are they going to do after the session? That they're not going to drive, they're not going to be engaged in drinking alcohol, and they're going to avoid stress. And then days following the ketamine treatment, you try to get them to connect with their therapist to recreate the experience, and then write down any insights that may have. Dr. Papp has them keep daily record of their depression after each session. That's encouraged, but many people forget to do that until right before the session with him or with me, to fill out this sort of tracking sheet. We go through this, we talk about it, so it's sort of an education piece of it, and then we go even further, and they get this, and I won't go through this, super carefully, but they have to actually fill it out themselves. So I go through it with them. What are you going to do the days before? the day of your ketamine, what are you going to do afterwards? Because you'd be surprised, no matter how much you educate them, they're going to come in and do something that is not really helpful. Anyway, so that's how we do a good practice to try to follow the patient, from beginning to end. So what is bad practice? Well, it's this ugly slide. It's all sorts of stuff that people do. So there are providers that will treat anybody. You want ketamine? Come on in. They've got hundreds of people. We, of course, are a little biased. We think psychiatrists are the best to administer this, but many people don't believe that. There's no evaluation of what's happening, no measures to say, is this really helping or not helping, and treat any sort of condition. They're not adjusting the dose properly or having a consistent dose. You don't medically monitor people. So, for example, the oral ketamine, there's often no medical monitoring at all. And you're not really disclosing the potential bad effects of the ketamine, and you don't stop. You just keep going and giving to me as long as people want. So basically, these predatory business practices of money over the safety safety of the patient, more than just the safety, the efficacy. During COVID, lots of sort of ketamine things popped up, and many of them actually ended up going out of business when there was a decrease in the availability of ketamine, but still they proliferate. And hopefully there will be maybe some standardization of what should happen. I think that's what the conferences and the ASKP, American Society of Ketamine Providers, is trying to address is more of a baseline for how this should be done. So I have a couple minutes to just do a couple cases, and then we'll have some time for questions. I know I went over a lot of this material pretty quickly, and I do encourage you to contact us if you have questions. So here's the first case. So a 42-year-old woman with very severe chronic depression all her life, nergic, negative ruminations, low self-esteem and motivation, mild suicidality, increased startle, PTSD, insomnia, somatization, rejection sensitivity, and then medical issues of obesity, chronic pain, long history of bad ketamine sessions. She had 6 ketamine-assisted sessions, and it was just, I wouldn't say perfect, but it just went very well. Her depression scores for BDI went from a 29 to 11 from the initial to the last session. In fact, the last session I wasn't in with her. Instead, she recorded on, had a tape recorder. She recorded all her own feedback that she wanted for herself. So it was a very good outcome. But then after that, maybe 4 months later, we get this case. And this case looks like the same person, right? It's basically the same, female, same age, same symptoms, almost exactly. But it was a disaster. It somehow activated in her a dependency, not a ketamine dependency, but dependency on her providers. She would stay 4 hours and just ruminate, and it was not good. She wanted to keep coming, but it didn't seem to be doing any good. Her scores weren't improving, so we said, we're going to have to terminate the therapy. Here again, 2 cases, extremely different outcome. And then the third case is this 53-year-old man with this terrible, allergic, severe chronic depression since childhood. Just has been debilitated in every aspect. He was non-functional, isolated, low motivation. He had hypothyroidism. He had, a lot of medical issues going along with it. So the first thing that happened was that kind of look at what is his psychiatric history, what are the medications that have been giving him. And Dr. Papp did psychogenetic testing on him, and lo and behold, he was a rapid metabolizer of duloxetine, which was the medication he had been on for years and years and years, 15 milligrams for 15 years, and nobody had ever looked at. And so he was switched to desvenlafaxine, and then added some Buspar, and voila, his BDI went from 37 down to 15 within 2 months. So there was weekly psychotherapy. It turned out he had pretty severe OCD as well. And basically with this patient, you don't need ketamine. I mean, sure, you can get it, and it might be kind of interesting, but it's not going to do what it really needs to do. So not every patient is going to need ketamine that comes into your office. So the lessons learned from these 3 cases are that the response to ketamine treatment can be idiosyncratic. So 2 patients can have very initial presentations the same, but very different outcomes. And you never quite know what's going to happen. So you cannot promise people anything about the ketamine. You can say, here's the data, here's what we experience, here's what most people are experiencing, but we can't promise this will be effective for you. Some people do their 6 sessions and nothing happens. Sometimes people decide to do more 6 sessions because they have a little response and then they get a better response. But you don't know for sure. I would say with suicidality, that's the thing that almost every single time works. It's like a miracle drug. I've had numerous patients that have had, been suicidal all their life or very risky suicidal, and they get the ketamine treatment and it's gone, almost completely gone within the first session. So it's being used in some emergency rooms for that as well. And then the third case basically illustrated that treatment-resistant depression, which now is really an archaic term for difficult to treat depression, may just mean that it's been poorly treated depression. You haven't really given the medications that they need. So you need to stay open to thinking about it differently. You don't just book people for ketamine. You try to respond to how the patient is responding to the ketamine or to other medications. And just because they're on the ketamine does not mean you stop your traditional antidepressants. Antidepressants are meant to be used in conjunction with them.
Well, I'd like to thank you both for taking your evening to do this. Thank you all. We really appreciate you, and have an absolutely lovely week.